My name is Ayman Elsebaie. I'm based in Rashid Hospital, Dubai. And my talk today will be acute iliofemoral and iliocaval DVT, best candidates, and how I do it. The aim of DVT treatment is, first of all, to diminish the severity and duration of lower limb symptoms, to prevent post-thrombotic syndrome, to prevent pulmonary emboli, and to minimize the risk of recurrent venous thrombosis. In 2021, the European Society of Vascular Surgery issued clinical practice guidelines on the management of venous thrombosis. And in these guidelines, they recommend if there is a patient with acute iliofemoral DVT, you should always evaluate the risk of bleeding. If the risk is low, then early thrombus removal in selected patients with symptoms of iliofemoral DVT is recommended. And this recommendation has a class 2A, level A recommendation. And this recommendation comes from the following study, the Cabane study and the 5 years follow-up, and the ATTRACT study and its follow-up. And in these studies, they found that the post-thrombotic incidence was lower with early thrombus removal technique. However, it was not significantly lower compared with anticoagulation alone. However, the post-thrombotic, the development of moderate to severe post-thrombotic syndrome was lower with early thrombus removal, and this was significant compared with anticoagulation alone. However, the incidence of major bleeding was higher with early thrombus removal technique than anticoagulation alone. And this is why they recommend to evaluate the risk of bleeding. Because in patients with iliocaval DVT, in majority of cases, thrombolysis was used. In 2022, the Society of Intervention Radiology published the position statement on endovascular management of acute iliofemoral deep vein thrombosis. And they recommend again, in selected patients with acute iliofemoral DVT, mechanical thrombectomy can be considered. And who are these selected patients? These selected patients are patients who has a high risk to develop PE. It means patient who has an iliac or iliocaval DVT, non-elderly patient with moderate to severe symptoms. If patient is having severe symptoms, then they should be considered, because we know from the study that the development of moderate to severe post-thrombotic syndrome is lower with mechanical thrombectomy compared with anticoagulation alone. We should know also about the symptoms duration, pre-DVT function capacity, comorbidities, and bleeding risk. So what do we need? First of all, if we have a patient, we will do, first of all, an ultrasound. The ultrasound is done not to identify the thrombus. The ultrasound is done also to identify which veins are patent, which veins we can puncture, and access to the thrombus. Then we need a CT or MRI venography. And in this study, we will evaluate the extension of the thrombus, and we will evaluate as well the access site. And in the CT or MRI, we will evaluate if there is any mechanical compression in the thrombus caused the iliocaval DVT, such as a tumor or May-Turner syndrome. And we will look to if there is collateral veins, because in some cases you have an acute DVT on top of chronic. So collateral are the best indicator for this. When we start the treatment, the first thing, the most important step is to define your access site. Which vein I'm going to puncture, and is this vein patent and has a good inflow to the venous to the thrombus. So first of all, with we do it with ultrasound, we evaluate the popliteal vein, we evaluate the femoral vein, we evaluate the saphenous vein, and we evaluate as well the internal jugular vein, because in some cases where we have an extensive DVT, we access to the thrombus through an antigrade access from the jugular vein. This is an example where we have a patient came with some small pulmonary emboli here. We looked to the pelvis. We found a lot of collateral veins, and there is a huge thrombus protruding into the inferior vena cava, which is here. And so we accessed the patient through the internal jugular vein. We placed a filter device just proximal to the cava thrombus. And then this is, as you can see, we accessed the femoral vein bilaterally. There is no inflow, only collateral veins in the pelvis. You even cannot see the inferior vena cava. We advanced our wire through the iliac veins into the inferior vena cava. We did an angioplasty and stenting for the iliac veins, and the patient came after 3 weeks to remove the filter, and this is the follow-up of the complete recanalization of the iliac veins with good flow, and the filter was captured and removed. So there are too many devices on the market. They work completely differently. We have the angiojet, which is hydromechanical with an optional of pulse spray thrombolysis. We have a pure mechanical thrombectomy, such as clot retriever from Inari Medical, penumbra with aspiration thrombectomy, or the Asperex catheter, where you have a cylinder rotating through, and the thrombus is migrating through a window into this cylinder and transported out of the body. 2 years ago, the penumbra launched a Cat Lightning 12, which is a stainless steel tube, and it has a sensor which indicates the blood flow. And if you are in a free blood flow, then the sensor will recognize this and will stop a continuation aspiration. This result in reduction of blood loss. This is a 56-year-old female. She came to us with a severe swelling of the left leg, severe pain since 10 days, and symptoms of phlegmasia cerulodolens. Patient is in spite on anticoagulation. This is her symptoms after 10 days of treatment. We did an ultrasound, extensive DVT, the femoral veins, the popliteal veins, the tibial veins, everything is thrombosed on ultrasound. And you can see here in the CT a thrombus in the inferior vena cava extending into the left iliac vein. You can see here the severe swelling of the left lower limb. And this is here on the reconstruction. You can see the severe, the thrombus in the left iliac vein protruding into the inferior vena cava. So we couldn't find any patent vein in the left lower limb which we can puncture and achieve a good flow after a thrombus removal. This is why we went through the right internal jugular vein, we placed a filter, and then we advanced a 12 French sheet to the beginning of the thrombus, and then we started aspirating and fragmenting the thrombus in Antigrade technique, and then we placed a catheter into the profundal femoral vein, and we started thrombolysis over the night. And after 12 hours of thrombolysis, we did a follow-up venogram, and there was a very good flow on the vein, and patient symptoms were much better than before. So in conclusion, iliocaval DVT should be treated with mechanical thrombectomy plus minus catheter-directed thrombolysis. You have always to evaluate the risk of pulmonary embolism, They have always to evaluate the risk of bleeding. You have to consider age, severity of symptoms, symptom duration, and comorbidities. Thank you very much for your attention, and see you soon. Bye-bye.